Kia ora, good afternoon everybody, and thank you for that welcome and introduction. So my topic is the future of general practice. My challenge is to do that in 15 minutes. In declaring my conflicts, it really gives you an idea of the perspectives that I bring to this. I'm the Chair of General Practice New Zealand. I'm a member of the Federation of Primary Health New Zealand. I'm on the Alliance Leadership Team here in Capital and Coast EHB. I'm a trustee on our PHO, and most of all, I'm a GP. And being a GP, I'm a generalist, I'm not a futurist, so most of my remarks and comments are going to be based on my reality, my lived experience. So why? Why do we need to look at the future? Well, the world we live and play in is changing, and the drivers of that are pretty well established. They are demographic, technological, societal, cultural, and environmental. And that means that the patients, the people we care for, are also changing. They're aging, and everything that brings. They're becoming more diverse. Their expectations of what they expect from the system is changing. And the role that they can play in care, their own care, armed with knowledge and data, is changing significantly as well. And the world we work in is changing also. And Sam this morning talked about that this afternoon very, very well. As a workforce, we're aging. We're becoming more burned out with the complexity of care that we are facing, the demand that's on our day, the demand that fronts up in our waiting rooms. We're having to adopt emerging technologies into our working day. And at the end of the day, for a lot of GPs and the teams that we work with, we're just losing the joy of practice and the work that we do. So the way we operate now is becoming unsustainable. And that's not just general practice, that's the whole of our system. And not only is it unsustainable, but it's no longer fit for purpose. So and there's the other why, the why 2575, which is being very well covered in this conference already, so I won't delve into that deeply. And what's the what? What do we need to do? Well, we know what we've needed to do for over 40 years. If we go back to Alma Ata, which is 41 years ago now, it talked about health for all, health being a right, having primary care at the focus of health systems, and the patient at the centre of that. 20 years ago, Barbara Starfield talked about the evidence that strong primary care at the front and centre of a healthcare system can deliver better health outcomes at a lower cost. And the declaration of Astana last year called for all health systems internationally to invest in primary care. And now we have the Health and Disability System Review, which brought tears to my eyes. In fact, it brought 2 tears to my eyes. And what it said of Tier 1 was that strengthening the role of Tier 1 services plays an important in the system is critical. This view has been espoused for over 20 years, but progress has been limited. So we know what to do, we know how to gear up for the future, but we come to the other why. Why is this not happening now? And I would put to you, actually it is happening now, that the future is here already, it is just unevenly distributed. That's a quote from The Economist in 2003. Because here's another quote from Ernest Rutherford. We haven't got the money, so we need to think. And we see organic innovation developing when resource is most constrained. And boy, have we had those times over the last 10 to 20 years. So already we're seeing pilots, proof of concepts, organically developing, addressing current needs within the system. We're seeing patient portal and open notes, GP telephone triage, group consultations, breaking the confines of the 15-minute appointment being the only way you can interact with your doctor and practice team. We're seeing the tyranny of distance being overcome by telemedicine. We're seeing care location in different places in less intensive settings now, such as insulin starts in the community here in CCDHB and infusion services increasingly being delivered in the community. We're seeing better access to diagnostics. There have been pilots on access to MRI performed by ACC and ProCare, which is now being rolled out further. We've seen point-of-care testing, near-patient testing being piloted in Auckland's Regional Rural Alliance. And we're seeing ultrasound becoming more available. We're seeing ultrasound machines actually being located in rural practices and increasingly in urban practices and after-hours facilities. And we're seeing changes in the workforce. We're now seeing health coaches appear, health improvement practitioners. We're seeing clinical pharmacists working within practices such as the Hawke's Bay. And we're seeing technological changes. Pharmacogenetics is in its infancy. And we see an increasing number of apps and websites such as Health Navigator, which are helping patients manage their own care. So, the challenge is, how do we take organic innovation like this, move it with scale and pace, so that if it's a good idea, it gets spread across the country, it doesn't end up a workaround in a postcode lottery, and these innovations end up smack in the middle of the quadruple aim rather than disappearing down into the Bermuda Triangle where most pilots end up. And there's a whole science about how you make improvement happen like that, from letting it happen to helping it happen to make it happen. Because at the end of the day, if you want transformation, it needs transportation, something to take it into the future. Do we have examples of that around? Well, I believe we do. And an example of transformation, or a vehicle for that change, is the Healthcare Home and the Healthcare Home Collaborative, a new model of care. So what has that done? It's taken a number of like-minded organisations who have the hearts, minds and stomach for transformational change, taken their ideas, taken those building blocks and principles and moved them forward with scale and pace. It's taken those building blocks, it's described 4 different domains of activity, of urgent and unplanned care, proactive care, routine and preventative care, and business efficiency to support that. It's then described a number of elements to make up a model of care which is certifiable, but ensured that it's flexible enough that it can be applied in a local context and contextualised to a location. And it's ensured that key to it ensures that there are benefits to the patient, like giving them access to their records, to their laboratory results, to their doctors, their care teams. Ensured that there are also benefits to the general practice themselves, because none of this occurs without a sustainable workforce. It gives services such as clinical triage, which value patients' time. If they don't need to turn up to the practice and can be sorted out over the phone, then that's what we should do. It gives them better access to information, appointment books, their records, their care plans, and it really does, for the first time, give people a chance to not just be recipients of care, but actually participate in their care and be far more self-determining. And it encourages care to be delivered by a team rather than individuals. So how successful has it been? In 3 years, we now see 1 in 4 New Zealanders covered by healthcare home practices. And I would describe that as moving innovation at scale and pace. Does it work? So Midlands Health Pinnacle ran some research in 2017 and again in 2018, and they found from that analysis that they found decreased emergency department attendances, particularly for Māori and for the over 65s. They found that there was an improvement in on-day availability of appointments. They also found there were fewer ambulatory sensitive hospitalisations as a result of this model of care. Does it work in other DHBs and localities? So the challenge for Midlands was workforce and sustainability of practices. They'd done a calculation in 2014 that by 2025 there'd be 1.5 million GP consultations short. In Capital and Coast, there was a different shake-up going on. We realised in about 2012 that there was increasing acute demand on hospital beds, and there was a 4% year-on-year growth in demand, and that this would be no longer sustainable. And that this was a problem not just for the hospital, but for also general practice. So we embarked on our own healthcare home journey at that point. Keys to the success for CCDHB have been that it was a joint venture, and there was both PHOs and the DHB were co-invested in this, and so both had skin in the game. We already had a functional alliance leadership team with established principles and values, established trust, established leadership. We developed a healthcare home support team which was then tasked to manage the change management, which often gets forgotten in these changes. Does it work? So within 3 years, we now have 80% coverage of patients in CCDHB and Wairarapa covered by healthcare homes within 3 years. Again, an example of moving innovation at scale and pace. In evaluating it, it was really important to make sure that we were covering all populations, not just mainstream, but also Māori and Pacific and other priority patients within our DHBs. And in the evaluations, we've seen that appointment availability for high needs patients has come down from somewhere around just under 2 weeks to get an appointment, a routine appointment with a doctor, down to just under 2 days. So access has been improved significantly. And like Midlands, we've seen an improvement in reductions of ED attendances and acute admissions, particularly for Māori and Pacific. And we've also seen a similar downward trend with ambulatory sensitive hospital admissions as well. So what next for CCDHB? Can we get beyond 80%? Well, it's still climbing, but the next important bit of work is actually taking clusters of those healthcare homes and developing healthcare neighbourhoods, if you like, and linking those to the community services that exist in those localities. So taking and grouping up so that there are populations of around 30 to 50,000. Developing what we call community health networks and linking general practices and their teams with people who are also delivering care in the community. Care Coordination Centre, district nursing, allied health, community pharmacy, geriatric services, and really clustering those services around the people that we care for. When you've got momentum and hubs like that, you can then start to develop other services. And one of the services that's been developed in the Kapiti region is the Community Acute Response Service, which aims to try and reduce the number of hospital transfers from Kapiti Coast down to Wellington and Kiniperu emergency departments. And in the first month of operating that, there have been 25 less ambulance transfers, a huge saving, not only to the system, but also the community. It's gifted them back time. So, what next, and what are some of my predictions for the future? I believe the way you interact with your practice will change significantly. There will be an increasing number of channels by which you can talk to your GP and your practice team, and there will be increased bandwidth, the number of words, the number of people you can talk to. I think that will be both active and passive, synchronous and asynchronous, and we will see alternatives to face-to-face with other non-face-to-face modes of consultation. I believe Patient Portal, in my opinion, has been the most transformational change that Healthcare Home has introduced, and I will see that become business as usual. We already see patients who will only join practices now who offer Patient Portal, having been exposed to it. And I believe we will see a growth in telephone consultation, e-consultation, and virtual consultation via video. Patient participation. I see that happening at all levels, not only in self-care, but also in service design of our facilities, and also patients getting involved in governance so that they're in the upstream conversations in their care. And that movement, as we've heard of from today, about people self-caring to actually being person-directed and directing the care, choosing who they partner with and how they receive and consume their care. Integration, I see there being more vertical integration between Tier 1 and 2. Clinical pathways are here now. Currently we have community pathways, we have hospital pathways. I believe they will become more of a continuum. So pathways have been a really good way of reducing unwanted variation. I believe that if we join up the pathways, we will see unwarranted variation of care being addressed in terms of where someone presents in the system. So if someone presents with concussion in general practice or at an after-hours facility or an ED, they will receive the same care. I see a continued process of specialist knowledge which is siloed and locked up within a hospital, being driven down through the system, more accessible to community and general practice teams, more available to patients. And I see when something is unpredictable and needs a specialist's attention, that their specialist advice will be available in a more easily accessible and timely fashion. I see alliance leadership teams becoming more mature, more independent, and having a wider membership. And I see more planned devolution of services. The Minister talked about the planned care initiative, which has recently been launched. I see that actually starting to see services being devolved from hospital settings into community and less intensive settings in a more formal way with the resource and the support attached to it. Something that we've talked about for years, but it doesn't happen. I see increased data sharing, and we may or may not see an electronic health record platform eventuate in the next 5 to 10 years. Integration also I see happening horizontally. It's happening to a degree, but bearing in mind that clinical care only constitutes about 20% of a person's health and well-being, we rely so much on what the other sectors offer. And I see the IDI infrastructure as being key to actually informing the system, telling the stories that will allow the right changes to happen in the intersectoral integration space. Models of care. I think the models of care around will continue to develop, those such as the healthcare home, whānau ora. I think there will be increasing recognition of what complexity drives in terms of the approach that's needed to address high needs populations and the resource that goes with that. I think we will see increasing care delivered in the community, development of community hubs of those 30 to 50,000 groupings, which will allow better planning for localities. an evolving workforce, and a return of the joy in working. So for the workforce themselves, I see a repurposing of our current workforce, people working to the full breadth of scope that they can, new and exciting roles developing. Our workforce will become more multicultural, multi-professional, and I see general practice teams working more closely with community pharmacy, midwifery, allied health, and NGOs. They will move from being multidisciplinary to interdisciplinary, where they learn and teach each other. Blurring of the boundaries between who employs people on the team. A movement from those services which are co-located currently to actually being integrated around patient needs. And I see a big movement of people actually becoming the MVPs, the most valuable people on the care team, as they move from self-care to becoming far more self-determining, armed with knowledge and advice. Business models I see as a hybrid, being a mixture of public, private, and corporate, but I do see the value of practices returning, the joy of work returning to general practice, and in that sense, general practice becoming a more attractive career option for medical graduates, because we need to attract about 50% of our medical graduates into general practice. And I see increasing interest in ownership of practices as well. Digital and data, I think there should be a democratisation of data. We need data and analytics to be far closer to patients, the information far closer to the end users. And in that way, the value of data is far closer to those it impacts on. So with better data, people can be far better informed and can choose and make decisions for themselves. And if they can self-care, that will release capacity within current care teams to do the work that matters the most. Artificial intelligence is a continually growing space, and we're seeing that particularly with dermatology, radiology, symptom checking, and triage, and pharmacogenomics is in its infancy. So, if we can do all of that, we might be able to change the paradigm which we work in currently, of people becoming ill, receiving treatment, and being recipients of their care. If we can arm them with that knowledge and change the way we work, we can make them and allow them to become participants in their care. That will give them a chance to actually move towards wellness. And once people are well, they can then start thinking about prevention. And if they're in that space, finally they might be able to take ownership of their health, become socio-economically independent and self-determining. And I believe that is what will help them move to a state of wellness. So my final prediction for general practice in the next 5 to 10 years, I hope I can retire. Thank you.